Good evening, everyone. I am Narendra Chokse, your host for the day. On behalf of Torrent Pharma, I take this opportunity to welcome you all to the webinar on clinical updates on beta blockers. It is indeed my pleasure to extend a warm welcome to all our distinguished panel members who are nothing less than a legend in the field of cardiology in India. First of all, I welcome our program moderator, Dr. V.S. Narayan from KGMC Lucknow. I also welcome our speakers for the program, Dr. Sunil Kumar Modi from Apollo Delhi, Dr. Sanjeev Sharma from EHCC Jaipur, and I also welcome our panelists for the program, Dr. G.D. Ramchandani from Kota, Rajasthan. I am sure this unique platform where evidence and experience meet will help all of us to enrich our knowledge even during these COVID times. On behalf of Torrent Pharma, I welcome all distinguished delegates as well who have joined us for this webinar. Dear delegates, if you have any questions or comments, please use the chat box in the web page to send it to us. On behalf of Torrent Pharma, I once again welcome and I request Dr. V.S. Narayan to take the proceedings further. Dr. Narayan, please.
Good evening, everybody. Thank you, Torrent, for giving us this opportunity to be with my friends and my senior, Dr. Sunil Modi. I must say that Dr. Sunil Modi was my first contact in MD when I joined there as the non-paid or non-resident PG. I did my MBBS from Jhansi and reached there in 1979, and he was my first contact. And thereafter, he treated me like a younger brother and has always guided me all through my days I spent with him during MD and then DM cardiology at the Lakshmipad Institute of Cardiology at Kanpur. So he has been a guiding force as far as the medicine and cardiology training is concerned, and I highly respect him for his insights into the subject of cardiology. He was the first person to have started invasive cardiology in a private cath lab in North India, where he joined under Dr. Padmavati, the legend, at the National Heart Institute in 1984. And then he has been an academic coordinator for cardiology, and he's been teaching DNB students and PGDD students for almost 25 years. He has served as the Indian College of Cardiology as the president. He was there between 2013 and 2015. And then thereafter, leaving the National Heart Institute, he joined as a senior consultant interventional cardiologist in the Apollo Hospital, where he still works. And he has had a 40-year experience, more than 40 years of experience in the field of cardiology. So I'm sure everybody knows him so well. But then it is always a pleasure to talk about your friends and those who have helped you in your career so far. So welcome, Dr. Modi. And I think with your experience in cardiology, and you've seen beta blockers developing over a period of time, I think you're the right person to talk to us about how we can use, and we have been using beta blockers in the field of cardiology, whether it's hypertension and heart failure also now. Since our days, we have evolved from not using them to using them in heart failure and acute coronary syndromes and arrhythmias, and so many other indications. So let's hear Dr. Modi talk to us about how and where we should be using beta blockers. Sir.
Okay. Thank you. Thank you, Dr. Varun, for such a sweet presentation and introduction. And you are one of the best cardiologist contact that I have come across in my career. So without wasting much of time, I'll just quickly come to the topic. And what I'm going to do in next 20 minutes, 25 minutes is just give you a quick overall view of beta blockers, not confining to any particular kind of beta blocker, but just overall beta blocker therapy in cardiovascular scenario. So I'm starting my first slide with the so just a moment. I think I've gotten to the last slide. Okay. Give me 5 seconds. Okay. So beta blockers of course, in systemic hypertension and beyond. Beyond is inclusive of many other very specific indications. Hypertension is not corona or not contagious disease, but it is still #1 cause of death all over the world. We have to remember that. Why are we so much interested in every time in hypertension? Why treat hypertension? We have to treat hypertension definitely because treating effectively blood pressure reduces heart failure by almost 50%, stroke by 38%, so on and so forth. It reduces cardiovascular deaths by 21%. So there is a very, very effective gain when we treat hypertension. Diagnosing hypertension is one of the easiest way to diagnose hypertension is just to check it, and treatment, of course, nowadays is become far more easier than what it used to be. Diuretics, beta blockers, calcium antagonists, AC inhibitors, angiotensin II receptor antagonists, these are the main pharmacological modalities. Of course, others like alpha blockers and centrally acting drugs are there, which in majority of the cases, we are able to control the blood pressure with the help of combining these drugs. Of course, most of the patients need combination of the drugs rather than monotherapy. I like this comment, very old comment before Christ BC. Medicines are nothing in themselves if not properly used, but very hands of gods if employed with reason and prudence. I think reason and prudence are very, very important. Let's come to the beta blockers in treatment of hypertension. Beta blockers work in hypertension by several mechanisms: inhibition of central sympathetic outflow, slowing of heart rate, negative inotrope effect, thereby reducing the cardiac output, also suppressing the renin activity, so affecting the renin-angiotensin system is some of the important mechanisms of beta blocker leading to reduction of the blood pressure. Now, as I said, other than systemic hypertension, beta blockers have many, many therapeutic uses. I'm just going to show you the slide. You can read as many you like. Coronary artery disease, congestive heart failure, hypertrophic obstructive cardiomyopathy, hyperthyroidism, pheochromocytoma, and so on and so forth. So beta blocker is not just blood pressure agent. It is also used in many other cardiovascular diseases. Now, I won't go again into the details of this. This is all theoretical and written in every textbook. How do beta blockers show the cardiovascular benefits? Some of the important one is that it prevents plaque rupture, thrombosis, decrease in the microvascular damage, inhibition of platelet aggregation, inhibition of myocardial apoptosis, of course, reduction of myocardial oxygen demand, and better flow to the ischemic areas is something which we already know for a long time. Now, sympathetic overactivity is a very important component in essential hypertension. About 1/3 of the hypertensive population shows sympathetic overactivity. Sympathetic overdrive with high plasma norepinephrine levels is usually seen in hypertensives who are younger age group, especially below 40 years of age. Obese, particularly centrally obese individuals who have hypertension, smokers, diabetic hypertensives, hypertensives with ischemic heart disease, and hypertensives with congestive heart failure. These are the special group of hypertensives who have been shown to have increased plasma norepinephrine levels and thereby indicating increased sympathetic overdrive. Beta blockade benefits central obesity, insulin resistance, diabetes mellitus type 2 through the mechanism of increased noradrenaline release. And if you see, beta blocker will help in every step in reducing arrhythmias, cardiac damage, so on and so forth. So all the bad effects of noradrenaline release can be at least partly taken care by beta blockers. So beta blockers are particularly useful in these subgroups of hypertension younger age group, obese, smokers, diabetics, ischemic heart disease, and congestive heart failure. This is just to show you the interesting, this is interesting slide that long follow-up, 9 years follow-up of UKPDS diabetes study in those patients who were both diabetic and hypertensive showed that beta blockers performed better than AC inhibitors. See, normally in diabetic hypertensive, we always say that AC inhibitors are drug of choice, but then long-term follow-up of cardiovascular complications on the left side, these deaths related to mortality, myocardial infarction, stroke, peripheral vascular disease, all the cardiovascular complications of diabetes were reduced more by beta blockers as compared to AC inhibitors, even in those diabetics, whom AC inhibitors are conventionally supposed to be the best. Now, there is all of you know that there is a recent controversy and change in the guidelines for the use of beta blockers as the first line therapy of systemic hypertension. And most of us agree to this, that beta blockers may not be necessarily used as first line therapy for systemic hypertension. There is enough evidence that first line therapy may be AC inhibitors, AR blockers, or sometimes diuretics instead of beta blocker. But then at the same time, most of the patients in sooner or later are going to need beta blocker as an additional treatment of in cases of hypertension. So I'm just going to show you 2 or 3 slides to to sort of get convinced and make you convinced that this statement of beta blocker not being used as antihypertensive treatment may not be all that true. Now, we know that all the studies which concluded that beta blockers are not the best drugs in the initial therapy of hypertension were done with atenolol. See, all these trials where the beta blockers were not better than other drugs belong to atenolol, and many of the trials which were done by other beta blockers, here, if you can see my arrow, were done by other drugs other than atenolol, showed that beta blockers may be a favorable drug. So this is one thing which we'll have to keep in mind, that the conclusion of beta blockers being not so good drug for hypertension was taken out from the atenolol studies. Same way with myocardial infarction, this upper one is for stroke, the lower one is for myocardial infarction, and the same thing. Most of the studies which showed beta blockers as poor choice were done by atenolol, and where the beta blockers were shown as better choice were done by the second and third generation beta blockers. So this is important. So problems with the ASCOT trial, which was the main trial which led to this concept, that beta blocker used in ASCOT trial was inappropriately dosed. Atenolol is not a once a day drug. That is what the interpretation was for this trial. And it is also well known that in the elderly, the beta blockers are not as effective in lowering blood pressure as calcium channel blockers or diuretic. And the average age in this trial was 63 years. So maybe that we were using wrong drugs at the wrong places, or the wrong drugs at the places where they were not supposed to be so effective. So with the atenolol concept and with the dose concept, this generalization was fluted. It was not agreed by many of the beta blocker lovers like me that beta blockers should be discarded as initial antihypertensive drugs. Now, are all beta blockers equal? Certainly no. We know that now with our experience of so many other newer generation beta blockers, that the beta blockers differ in potency, they differ in duration of action, cardioselectivity, membrane stabilizing activity, leading to suppression of arrhythmias, intrinsic sympathomimetic activity, so on and so forth. So particularly these cardioselectivity and some of the actions are very, very important when you choose beta blockers. Now, for example, beta-1 blocking potency has been compared, and you will be realizing that bisoprolol, carvedilol, and nebivolol, these 3 late generation or third generation beta blockers have 10 times more beta-1 blocking potency as compared to the atenolol, metoprolol, or propranolol. So here what the difference comes, that the late generation beta blockers are far more potent as beta-1 blockers as compared to the previous beta blockers. Nebivolol improves endothelial function. It has been shown in the study in the subjects with coronary heart disease. This is just to show the difference that all beta blockers may not be same, and you can always choose the beta blocker as per its specific use. So just kind of concluding for the hypertension, do not forget that there are compelling, specific and beneficial indications of beta blocker justifying their use even as first line agents for hypertension. So these are the groups where you can even think of using beta blocker in hypertension as the first line agents. If your hypertensive patient has had an MI, angina, heart failure, tachyarrhythmia, he's young with a lot of sympathetic overdrive, hypertension with pregnancy, glaucoma, thyrotoxicosis. So without any doubt, these are the groups, and being in the cardiovascular specialty, these first four are the group of people whom we see most often. Every second, third patient of mine has either one or two these conditions, infarction, angina, arrhythmias, or heart failure. So as a cardiovascular specialist, when we treat hypertension, beta blockers are never out of our mind. We always think whether this patient requires beta blocker or not, as against probably internal medicine people who may not think of beta blocker as the initial agent, but we practically always think of beta blockers. Unless there is a reason not to use, I'll always prefer using beta blocker for various indications. Now, another important subset is sudden cardiac death. In hypertensives particularly, prevention of sudden cardiac death, role of beta blocker. It's important. Statistics is that just a minute. How do I remove this one? Okay. Sudden cardiac death accounts for almost half of the cardiac mortality. Chances of dying suddenly is twice in hypertensives as compared to normotensives, and 6 times or 7 times more in cases of coronary artery disease as compared to the general population. Now, this is a bad statistics. If you are hypertensive, you have 2 times higher chances of dying suddenly. Beta blockers have important antiarrhythmic properties, and they differ from other antiarrhythmic agents that in the sense that they don't directly modify the ion channels. They are not channel acting drugs. Rather, they prevent the arrhythmias promoting actions of beta adrenergic stimulation. So why is it important that those antiarrhythmics which modify channel functions, they also are pro-arrhythmic, and they have been shown to increase the risk of arrhythmias. But beta blocker, being not ion channel dependent and directly hitting on the beta adrenergic stimulation, is probably one of the best antiarrhythmics to prevent sudden cardiac death. Hence, beta blocker are particularly useful in preventing sudden cardiac death due to ventricular arrhythmias associated with acute myocardial infarction, ischemia, congenital long QT syndromes, and congestive heart failure. So I think this is one of the best utility of beta blockers in cardiovascular medicine. There are enough trials, just to summarize, primary prevention trials, MEFI trial done many years ago showed that beta blocker is far better than diuretic in preventing sudden cardiac death as far as primary prevention of sudden cardiac death is concerned. Then there are a number of studies on secondary prevention of sudden cardiac death, number of studies on prevention of sudden cardiac death in patients of heart failure. I'm not going into details of this, but very convincing evidence that beta blockers, whenever used, they do help in significantly reducing the chances of sudden cardiac death. Now, another very important area for beta blockers is the heart failure. As Dr. Varun was telling you, when we were doing our MDs and DMs, we were especially told not to use beta blockers in patients of heart failure with the concept that they are going to make it worse. And the only reason of thinking that was that they are negative inotrope, and everybody thought that heart failure means you must use the drugs to improve contractility, and the digoxin was the only drug at that time. So anything not like digoxin was thought to be bad for the heart failure. Now, that was a wrong concept. Over years, in 90s, everybody realized that no, that is not the best way of treating heart failure. Finally, what we learned in late 80s and 90s is that Primarily, it is these two chemicals, angiotensin 2 and norepinephrine. Both of them are elevated in patients of congestive heart failure, much more elevated than the usual. And they are the ones who are the culprits. They will ultimately lead to ischemia, arrhythmia, remodeling, sudden death, apoptosis. So whatever can control angiotensin 2 and norepinephrine in heart failure is going to help patients of heart failure, both in morbidity and mortality. And there was very nicely shown evidence that plasma norepinephrine levels were higher the plasma norepinephrine levels, worse is the outcome of cumulative mortality in heart failure is high. So mortality in heart failure was directly linked to the levels of plasma norepinephrine, so elegantly demonstrated in these studies. So naturally, once you want to reduce norepinephrine activity, then beta blockers are the drug of choice. So there are interactions between beta blockers and many promoters of congestive heart failure and arrhythmia, not just one, endothelial 1, renin, QT-DIFFERENTIAL, beta-1 receptor, sympathetic tone, apoptosis, oxidative stress. So there are a number of reasons that beta blockers should help patients of congestive heart failure by reducing the beta receptor activity. The huge number of trials were done in 90s, 13,000 patients for the initial trials in heart failure. And what all of them showed a very consistent improvement in cardiac function, symptoms, and clinical status. There was a decrease in all-cause mortality by 30 to 35% in these trials when the beta blockers were used in heart failure. And there was a decrease in combined risk of death and hospitalization by 25 to 30%. So this is what was shown in the beta blocker trials in 90s. And you are very well aware of these major mega trials, MERIT-HF with metoprolol extended release, CBIS-2 with bisoprolol, and Copernicus trial with Carvedilol, which showed quite consistent, if you look at the bottom lines, 34%, 34%, 35%. So quite consistent results, whether you use this drug or this drug or this drug in heart failure. There was a very remarkable, almost like 1/3 of the patients are saved. The mortality is reduced by 34, 35%. Beta blockers then were also used in class 1 patients. Of course, most of the initial trials were done in class 2 and 3, but then they were also used in class 1 and then in class 4. And surprisingly, irrespective of the NYHA class, beta blockers were equally helpful, equally useful in reducing the mortality and the morbidity in heart failure. Now, which led to the indications, recommendations, 2001 consensus recommendations. Now, this is something which all of the people listening to this webinar or otherwise must remember, is that all patients, not some, not few, no, the word is all patients with heart failure due to left ventricular systolic dysfunction should receive a beta blocker, bracket, in addition to ACE inhibitor or AR blockers, unless they have a contraindication to its use. That means unless they have a contraindication to the use of beta blocker, or patient cannot tolerate treatment with the drug. Now, this is what I want to emphasize here. It's not your choice. It's not that you forgot to use beta blocker in heart failure. All patients you must use unless there is a reason not to use. So you have to identify the reason. If you're not using beta blockers in systolic heart failure, you must specify the reason in your records or in your file or in the patient record that I'm not using beta blocker in this systolic heart failure because of this reason. Because invariably you will be benefited, patient will be benefited if you use heart failure. So all patients, not some, not few, not most, it is the all patients with systolic dysfunction heart failure should be given beta blockers. Now, people started doubting, in the initial phase that whether patient will be able to tolerate beta blocker in heart failure. So tolerability was the question in the beginning, at least. And now as we are using more and more, we are learning more and more. But then in the beginning, tolerability, so it was shown very clearly by the trials that tolerability as far as worsening of dizziness, worsening of heart failure, and bradycardia. These were the three main concerns in using beta blocker in heart failure, that patient will get dizzy because of fall of blood pressure, patient will get worsening of heart failure, patient will get brady. So all these so-called factors were more common in placebo arm as compared to the beta blocker arm, both in the US Carvedilol and MERIT-HF study. This is important. Placebo had more worsening of heart failure as compared to the beta blocker arm. Bradycardia, not significant. Dizziness worsening, not significant. So as far as tolerability is concerned, the beta blockers were tolerated very well in these heart failure trials in the beginning of its use. So thereby the drug discontinuation was not really much. The placebo arm discontinuation rate was more than the drug arm. US Carvedilol study, same way CBIS-2 study and MERIT-HF study. So as far as side effects are concerned, all these trials landed up discontinuing more in the placebo arm as compared to the beta blocker arm, certainly telling us that beta blockers doesn't need to be discontinued in most of the cases. Why do physicians not give beta blocker still in patients of heart failure? I'm just emphasizing the same thing again with some more data. Myths about side effects and tolerability. Patient is too old for beta blocker. Patient has COPD. Patient has diabetes mellitus. Patient has blood pressure which is too low. Patient has ejection fraction which is too low. And beta blockers cause impotency, claudication, depression. These are the most common concerns of the physician for not using beta blockers in heart failure. Let's just go one by one. Is too old for beta blocker. The data has very interestingly shown, nicely shown that elder is the person, more is the advantage of beta blocker in heart failure. Above 65 age, you get more advantage. So just the other way around, what we think. Elderly is the person, more is the advantage of treating them with beta blockers. Patient has COPD. So how can I use beta blocker? It's absolutely wrong to think that COPD patient with heart failure. See, we are not using beta blockers for COPD. We are using beta blockers in a COPD patient with heart failure. So data is very clearly there that MERIT-HF study showed that placebo arm has much more problems in COPD group as compared to the beta blocker arm. So any respiratory adverse event, more in the placebo arm, less in the beta blocker arm, whether you talk of infection, dyspnea, pulmonary edema, hemoptysis, so on and so forth. So if at all beta blockers in heart failure do not worsen the COPD, if you are using it for the heart failure in patients of COPD. The COLA trial, very famous trial, Carvedilol open assessment study showed that 85% of COPD patients will easily well tolerate beta blockers in heart failure. Of course, 15% will not tolerate. That is true for every drug. So we should identify these 15% COPD patient who will not tolerate beta blocker and may not give beta blocker to these patients, but then depriving rest 85% for the advantage of beta blocker in heart failure in COPD patients will not be the best way to treat these patients. Physicians hesitate that patient has diabetes mellitus, so let me avoid beta blocker. Diabetes mellitus is no reason to avoid beta blocker in heart failure, has been shown again and again. Because diabetics have higher morbidity and mortality in heart failure, so higher is the mortality of heart failure, more is the benefit of using beta blocker. So we just think the other way around. Because diabetics are high risk, they will get more advantage of using beta blockers. Patient has blood pressure which is low, so I don't want to use beta blocker. Has been shown nicely, blood pressure lower than 120, blood pressure above 120, compared, no difference. So beta blocker in heart failure is not related to the initial blood pressure. If you are improving heart failure, you are also improving the blood pressure. So do not hesitate in starting the beta blockers if the blood pressure is not of your choice. Patient has ejection fraction which is too low. If I use beta blockers in ejection fraction of 12%, patient may have more complication. No, that's not true. Interestingly, the data from the large trial showed that ejection fraction less than 25, ejection fraction more than 25. The lower ejection fraction group got more benefit with beta blocker as compared to the higher ejection fraction patients, just the other way around. So diabetes, low ejection fraction, these are the groups who are at higher risk, and they should be definitely given beta blockers to reduce the risk. Lastly, beta blockers cause impotence, claudication, depression. Yes, they do cause, but then interestingly, compared to the placebo arm, in heart failure patients, those patients who were on placebo got more depression. Those patients who were on placebo got more anxiety, other psychiatric issues. So all psychiatric adverse events were much more in the placebo arm as compared to the metoprolol arm. So thereby telling us that, again, this is no reason to shy away from using beta blockers, which are actually life-saving. You know, you are talking of a life-saving drug. You're not talking of just a symptom-improving medicine. So patients with peripheral vascular disease are commonly the candidates for beta blocker due to coexisting hypertension. In a randomized placebo-controlled crossover study, beta blocker therapy did not significantly alter claudication distance, walking distance, or food temperature. So finally, if you use beta blockers in heart failure, you save 70 lives in class 4 patients when you use it in 1,000 patients as compared to the other preventive therapies which are there in front of you, like ramipril in HOPE trial, enalapril in SALT prevention. So the Carvedilol in class 4 patients is one of the most effective way of saving life in advanced heart failure. So challenge to all of you in treating heart failure is that whereas the 80 to 85% patients with heart failure should be ideally receiving a beta blocker, that is the statistics, but unfortunately less than 25% of patients. It used to be less than 10% 10 years ago. It is improving. Now current data says, collected from various sources, is that approximately 1 out of 4 patients where beta blocker is clearly indicated in heart failure receives beta blocker. So still 75% of the patients who should be ideally on beta blockers in heart failure are not on beta blockers. So this is a challenge which I think all of us as physicians must accept. Now I'm finishing my talk again by showing you the same slide which I have shown many times. Wisdom lies not in the amount of knowledge acquired, but in the degree of its application. So we know many things. We know that beta blockers are very helpful in heart failure, certain cardiac death prevention, but then we do not apply our knowledge. So this is how I'll just wrap up and finish and hand over to Dr. V.S. Narayan.
Sir, thank you very much, sir. I think that was a very balanced and great summary of how we should be looking at beta blockers in the present day cardiology practice. You're right that while the guidelines have been rather cruel with beta blockers as far as hypertension management is concerned, we as cardiologists, we never forget about beta blockers. Most of our prescriptions will have beta blockers because most of our patients do have those associated conditions of hypertension with angina, with diabetes, with heart failure. And even for uncomplicated hypertension, I think beta blockers will be used after we exhausted our armamentarium of beta, ACE inhibitors, calcium channel blockers, and aldosterone antagonists. That's the place where you will actually like to add a beta blocker, or perhaps in a young individual who has tachycardia and who has a lot of anxiety and sympathetic overdrive. So hypertension per se, yes, in certain cases, and of course hypertension with certain conditions associated, beta blockers have an important place. Now, as I forgot to mention when I was introducing Dr. Modi, he has a special interest in heart failure, and he's very rightly emphasized that each and every patient of heart failure with reduced ejection fraction needs to get a beta blocker. And we have issues like, that the patient's high diabetes can get disturbed, or we have issues that he will have some kind of COPD exacerbation or even impotency. But I think we can discuss, and Dr. Sharma will probably take it up. Since all beta blockers are not the same, then perhaps in these situations we can have a place for Nebivolol, although its usage has been rather limited in these situations, but we can certainly start thinking about using Nebivolol in patients with heart failure especially who are diabetics or who are obese and who have some kind of COPD also, or there is some kind of impotence which is being reported. And I'm very happy that Daksab has pointed out about peripheral arterial disease, because there's something in our mind that giving a beta blocker will exacerbate pulmonary artery with peripheral arterial disease. But since PAD by and large will be associated with coronary artery disease, I think use of beta blockers is going to be a lifesaver there. So I think with that, with that background also, I would, and there's a question in my mind, since the heart failure is a continuum, and we'll take that question up later, why not start using it even in patients with preserved ejection fraction or mid-range ejection fraction? Why only with those reduced ejection? Because sympathetic overdrive will start and give you a whole spectrum of heart failure. So maybe we could start using beta blocker even in those conditions, because hypertension per se will have some degree of preserved ejection fraction like heart failure, reduction of longitudinal strain, etc. So we'll take the questions later, and now let me introduce to you all my friend Dr. Sanjeev Sharma. He has a longer 20-year experience in interventional cardiology. He has worked in one of the leading centers of the country, started with AIMS, worked in Fortis Escorts Hospital, and now he has shifted over from Delhi to Jaipur, where his main area of interest is coronary interventions and complex coronary interventions, calcified coronaries, left main interventions, post-bypass interventions. And I'm sure you're also doing the shockwave therapy since you're, want to tackle calcified lesions. So maybe we'll move on from hypertension and ask you a few questions on that. So he has been awarded many distinctions from Jaipur, and he's been the top cardiologist of Rajasthan also. And he has so many national and international publications. And he keeps giving us talks, and we get enlightened by his views also on these fora and on other national fora. So with that, I will need to invite him for his talk on vasodilatory beta blockers. As was pointed out by Dr. Modi, not all beta blockers are the same. And we're especially interested in the beta-1 selectivity and vasodilatory properties of beta blockers in our patients with hypertension and those with heart failure. So over to you, Dr. Sanjeev Sharma. Let's hear you on the vasodilatory beta blockers. Dr. Sharma.
Good evening, everyone. And first of all, I would like to appreciate efforts from the Torrent Pharma for organizing this hypertension symposium today evening. And it's great to have Dr. V.S. Narayanan as a moderator for the session. And after a great talk from Dr. Modi, it was a very nice overview, and he touched all the aspects of beta blocker use in a cardiology, right from hypertension to heart failure in a very detailed way. He touched all the important salient points like underuse of beta blocker and very limited contraindication. The people are not using to the extent we should use it. And as Dr. Narayan said, not all the beta blockers are same. And we do have a beta blocker which has an additional vasodilating property. Let's look into that subcategory and how it is beneficial in the use of different indications in our routine practice. Now, is it a beta blocker is a class effect, or do we have a different agent with a different effect so that we can tailor our therapy for hypertension and the heart disease on the basis of those properties? Like up till now, most of the guidelines, they don't categorize these different beta blockers as different classes. They do have a just single class as a beta blocker. Whether it's a hypertension or the heart failure, they do categorize as a single class of drug with the beta blocker. But these beta blockers are having a different properties on the basis of cardioselectivity or intrinsic sympathomimetic activity and lipophilicity, and the most important one is vasodilator properties. And the other important thing is a metabolic effect, whether it's insulin resistance or effect on lipids. All these beta blockers are not same if you consider all these properties. And like it mentions, in particular, vasodilating beta blockers like labetalol, carvedilol, nebivolol, ss-blockade, these seem to overcome the general limitation of conventional beta blocker as a class effect. They do have other properties like alpha blocking property or kind of increasing the NO synthase and thereby causing vasodilatation and endothelial function improvement. And these agents seem to have a better metabolic profile as compared to all the beta blocker. When you consider insulin resistance, they cause less insulin resistance or improve insulin resistance at times. They don't seem to worsen the glycemic index. Like beta blocker is a class, we do say that it can present new onset diabetes, but these vasodilator beta blockers, they improve insulin resistance and cause less diabetes on the follow-up. And also, they do have a beneficial effect on reducing the central aortic pressure or central pulse pressure, and also reduces aortic stiffness, and which is considered to be a class effect for the other antihypertensive like ASCOT trial, which discussed by the Dr. Modi, that in that trial, the central aortic pressure was reduced by the combination of perindopril and amlodipine. But as a beta blocker class effect, it was compared with the atenolol, which doesn't have any effect on central aortic pressure. But these agents, vasodilator beta blocker, especially nebivolol, it do reduce central aortic pressure and reduce the aortic stiffness. Thereby, it has a almost same effect what we see with the other beneficial drugs like calcium blocker and the ACE inhibitor in reducing the stroke risk. Now, coming first to the carvedilol in a very brief, it is a non-selective beta blocker. It blocks alpha-1 as well as beta adrenergic receptor. And it has been tried in the various indications, especially in the heart failure and also in the hypertension. And all these trials, this agent was found to improve the endothelial function, reduces platelet aggregation, and reduce the inflammation also. And it also preserves the nitric oxide bioactivity. This is a very important part. All the beta blocker, which improves the nitric oxide bioactivity, improves the endothelial function, and also having vasodilatory effect. And in hypertensive diabetic patients, carvedilol was found to have an improvement in the glycemic control. It doesn't worsen the glycemic control by improving the insulin sensitivity. This is very important. Not all the beta blockers are same when you consider the insulin resistance and the glycemic index. But these vasodilating beta blockers, particularly nebivolol and carvedilol, they improve the insulin resistance and helps in managing diabetes as a neutral. Now, coming to the molecule of the evening is nebivolol, which is not being discussed as often in the different meetings. This is a very important, very highly selective beta blocking agent, very highly selective as compared to the other beta blockers, metoprolol, bisoprolol. It's more selective beta agonist as compared to other agents. And it also has a vasodilating property by way of activating the L-arginine nitric oxide pathway. This is a pathway which is specific to nebivolol, and thereby it causes vasodilatation. And this agent has a very favorable metabolic profile. As discussed, it improves the insulin sensitivity, and thereby it improves the glycemic status of the patient, or doesn't worsen the glycemic status of the patient in diabetes. And it doesn't have a deleterious effect on the lipid profile. Rather, it is neutral for the lipid profile as compared to the other beta blocker, which tend to increase the triglyceride to some extent, increase the LDL a little bit, and reduces HDL. But this is relatively neutral for the lipid profile, and which is very important when we are treating the CAD and other atherosclerotic disease. And it improves the endothelial function. And by improving endothelial function, as discussed, by activating the L-arginine nitric oxide pathway, it reduces the aortic stiffness and thereby reduces central aortic pressure, which is very important property when we look into the beta blocker. Because as discussed, not only the cardiovascular events, but also the stroke risk decreases if you reduce the central aortic pressure by reducing the aortic stiffness part. And as pointed out by Dr. Modi as well as Dr. Narayan, very troublesome side effect remains the erectile dysfunction. But by use of this beta blocking along with the vasodilatory property and by increasing the NO synthase, it in a very significant way, it reduces the incidence of erectile dysfunction as compared to other beta blocker. Very small fraction of the patient, they encounter erectile dysfunction, or majority, they don't have erectile dysfunction. So whenever we want to switch with a beta, because impotence caused by the beta blocker, whether it's a metoprolol or atenolol, if we switch to Nebivolol, there is likelihood that erectile dysfunction should improve over a period of time. Now this question arises, should we consider beta blocker as a single class of antihypertensive, or do we have to differentiate among beta blockers according to their specific properties, as discussed, like a vasodilating property, or because of a neutrality on a lipid profile, or by improving the insulin resistance? Should we have a different indication for the different beta blocker? Now, to address this question, in 2018, European Society of Cardiology and European Society of Hypertension, they had a detailed statement which mentions the beta blocker are not a homogeneous class. And in the recent years, the use of vasodilating beta blockers such as labetalol, nebivolol, celiprolol, and carvedilol has increased. And the studies on nebivolol have shown that it has a more favorable effect on central aortic pressure, more favorable effect on aortic stiffness, it improves the endothelial dysfunction, and so on. It has no adverse effect on the risk of new onset diabetes, and a more favorable side effect on the lipid profile, and then the other classical beta blockers, including less adverse effect on sexual dysfunction. So this is the statement by the European Society of Cardiology and also by the European Society of Hypertension. And this also mentions that bisoprolol, carvedilol, nebivolol have been shown to improve the outcomes in randomized control trial in heart failure. This is one of the additional comment by that. But it's very important that all the vasodilator beta blocker, they have a favorable metabolic profile, reduces the incidence of new onset diabetes, they maintain the lipid profile very neutrally, and also reduces the incidence of erectile dysfunction. As we discussed, the insulin resistance is quite common with the beta blocker, and the precipitation of new onset diabetes is also common. But by introduction of these vasodilating beta blocker, we can avoid this insulin resistance or reduce the insulin resistance to some extent. And also it is a neutral for lipid metabolism. And this clearly shows the highly beta selectivity of the nebivolol as compared to other beta blockers like bisindolol, carvedilol, metoprolol, bisoprolol. And we used to consider bisoprolol as very cardioselective, but over and above, if you look into the comparison with the bisoprolol, nebivolol is highly cardioselective. And we look into the reduction in the peripheral vascular resistance. Then you see it's a 13.2 dynes per centimeter cube reduction in the peripheral vascular resistance as compared to the baseline by this nebivolol. And this really translates into the improvement in the cardiac output and also in the stroke volume. And it reduced the heart rate by -7. So it favors all important parameters when you look into in terms of blood pressure reduction and also improvement in the cardiac output and also in the patients with the heart failure. Now, regarding an insulin resistance, this is very important bar diagram. On the left side is a nebivolol, on the right side is a metoprolol. So as compared to the baseline, over 6 months, you can see the significant reduction in the insulin resistance, right from 2.79 at the baseline to 2.29. It was a statistically significant. So nebivolol affects very favorably when you consider the insulin resistance. As compared to the metoprolol on the right side, you can see the insulin resistance increased from 2.67 to 2.83. This is how it has increased by the use of the metoprolol, but there was significant reduction in the insulin resistance by the use of nebivolol. When you look into the lipid metabolism, nebivolol is relatively neutral, and you can see left one is an LDL, On the right extreme is a triglyceride, and in between is the SDL. And relatively neutral on lipid profile. There is no significant increase in LDL or in triglyceride or the reduction of the SDL by the use of nebivolol, whereas other agents significantly increase the triglyceride and reduce the SDL. Now, there are few studies which I'll be discussing in brief on the use of nebivolol in different indications. Now, first one is the YESTONO study about the use of nebivolol in hypertensive patient with a background of diabetes. So this was a prospective open label multi-center post-marketing surveillance study, and in which a reasonably good number of patients, 2,838, close to 3,000 patients were with arterial hypertension with the background of diabetes were taken, and with or without other diseases like cardiovascular disease. And the results were like nebivolol significantly reduced the mean systolic pressure by 21 millimeter mercury over 12 weeks, that is almost 3 months, and reduced the diastolic pressure, mean diastolic pressure by 11 millimeter mercury, which is quite significant if you look into the 3 months of time, and also reduced the mean pulse pressure by 10 millimeter mercury, and it reduced the heart rate by 8.6 or 9 beats per minute. And it clearly reveals that in this trial, the strict BP reduction in the hypertensive patient with the background of diabetes with without other concomitant cardiovascular disease is achieved with the nebivolol by the dose of 5 milligram per day, which is a standard dose to begin with. Either a 2.5 is a very small dose, or 5 milligram is a standard dose, and then you can go up to 10 mg or at times 20 mg of nebivolol. And the benefit of lowering of the this blood pressure with the use of nebivolol associated with improvement in the most metabolic parameters. When you look into metabolic parameters, is improvement in the glycemic index and also improvement in the lipid profile. Now going to the next one. This is the trial in which the differential effects of nebivolol and metoprolol on central aortic pressure and the LV wall thickness was observed. And it was a randomized study, double blind, in 80 hypertensive patients were randomized either to nebivolol or the metoprolol, and it was looking into the reduction in the central aortic pressure and thereby reduction in the LV wall thickness. And when we see the result, central aortic pressure, this is the baseline in the two arms, nebivolol versus metoprolol. And you can see in nebivolol arm, there was significant reduction in central systolic pressure as compared to metoprolol, which was almost statistically not significant. In the same way, the central diastolic pressure was also significantly less in nebivolol as compared to metoprolol. And this translates into reduction in the LV wall thickness. And this was statistically significant in nebivolol arm as compared to the metoprolol arm. So it clearly says by reducing the central systolic and diastolic blood pressure and the central pulse pressure, it reduces left ventricular wall thickness, which is a very important marker of the future cardiovascular event. And that was seen only in the nebivolol group as compared to the metoprolol group. So this study provides clear evidence to suggest that beta blocker with vasodilating property like nebivolol may offer advantage over conventional beta blocker in antihypertensive therapy. And now this is about the risk of hospitalization for cardiovascular events with beta blockers in hypertensive patients. In this very important study or evaluation, it was nebivolol was compared to atenolol and metoprolol, and this was like a propensity score meta-analysis kind of a design in which a good number of nebivolol patients were compared with the atenolol and metoprolol, and it was found that all the adverse events like composite cardiovascular events were significantly low in nebivolol arm as compared to atenolol and metoprolol. Similarly, the incidence of MI, heart failure, stroke, and angina, they all were significantly less in nebivolol as compared to the atenolol and metoprolol. This was a comparison on the basis of the previous trials or meta-analysis, and it was a propensity score matched analysis. We cannot generalize all these as a clear-cut comparison But still, with such a big number of the patient, all three different classes, there was significantly less composite cardiovascular events, MI events, heart failure events, stroke, as compared to the atenolol and metoprolol. So it clearly shows superiority over other agents. And the same in a like a forest plot in the this is a central one is this is the baseline by the Nebivolol, and if we compare with the atenolol, this was all in favor of Nebivolol, because it's not going. It is clearly in comparison to atenolol, all the effects were more in this group as compared to Nebivolol, if you find it on this side. And we are comparing the metoprolol also. It goes in favor of Nebivolol when you look into all the cardiovascular events. And we look into the hazard ratio of all the events, they were clearly, as compared to Nebivolol, were high in atenolol as well as metoprolol arm. So Nebivolol associated with significantly lower risk of hospitalization due to composite cardiovascular events than atenolol and metoprolol. So it clearly says all the cardiovascular events were in this meta-analysis was found to be higher in atenolol and metoprolol arm as compared to the Nebivolol arm. Now about the specific population, majority of the hypertensive patients, they do have other overlapping risk factors and diseases. And the vasodilator beta blocker like Nebivolol have a significant role in the setting, because these hypertensive, they do have a diabetes, or they do have a deranged lipid profile, or having a concomitant cardiovascular disease, or the peripheral vascular disease, or stroke. In these patients, like very much cardioselective as well as vasodilating beta blocker have a beneficial effect. And in addition, vasodilator beta blocker have been proven to have a good BP lowering effect, and with excellent safety and side effect profile. These are both the prerequisite for the benefit of any antihypertensive therapy, the proven efficacy as well as proven safety. Now, this is one of the study in which combination of Nebivolol plus hydrochlorothiazide was compared to the irbesartan plus hydrochlorothiazide in the treatment of isolated systolic hypertension in elderly patients. This was a NICE study. So elderly individuals with isolated systolic hypertension, and combination of Nebivolol plus hydrochlorothiazide was compared to irbesartan plus hydrochlorothiazide. And this was a multi-center randomized study, and with a follow-up of 12 weeks, 124 patients were randomized in the age group of 69, almost 70 years of age. And the dose which was used was 5 mg of Nebivolol plus 12.5 hydrochlorothiazide, and it was compared to 150 mg of irbesartan plus 12.5 hydrochlorothiazide. And this was followed up for 12 weeks time, and it was found that reduction in systolic BP with Nebivolol plus hydrochlorothiazide was significantly greater over 12 weeks time, but the reduction in the vascular BP was significant for the first 8 weeks, but not at end of 12 weeks. When we look into the 24 hours BP control or the daytime nighttime control, these were almost similar in the two groups. So the ambulatory BP monitor for the 24 hours and also the nighttime was almost same in the two groups. And heart rate reduction was as expected with beta blocker like Nebivolol was significantly significantly better as compared to the irbesartan group. So Nebivolol plus hydrochlorothiazide combination reduces the office BP more than irbesartan hydrochlorothiazide, but the similar effect on the 24 hours BP. So 24 hours BP, ambulatory BP was almost same in the two arms, but office BP was significantly less in Nebivolol arm. And when you consider the BP variability, it was definitely better with Nebivolol arm as compared to the irbesartan hydrochlorothiazide arm. So two important points. Number one, the BP variability was less with Nebivolol as compared to the irbesartan hydrochlorothiazide. And number two, the systolic BP reduction was significantly better with Nebivolol, and the 24 hours BP monitoring was almost same. Now, this is about the senior trial, which looked into elderly patients with a heart failure and with a concomitant impaired renal function. This is very important. The elderly patients with a heart failure and renal dysfunction. In this clinical scenario, the Nebivolol was found to be superior as compared to the, it was compared to the placebo, I think. And in mild to moderate renal dysfunction, even in the elderly patients, they had usually you have a little challenge. There should not be present a limitation to the use of Nebivolol in heart failure patients. This is a very important indication in heart failure with a mild renal dysfunction. We are using all the beta blockers, and Nebivolol has been found to be better in this scenario in senior trial. Now, when we look into the obese and non-obese hypertensive patients, this was a study which analyzed the 3 multi-center randomized placebo-controlled trial. It was not compared with any agent, but it was compared with the placebo. And this Nebivolol was found to have a significant benefit in equal to more than 2.5 milligram dose and also equal to more than 5 milligram dose. And benefit was in both the category, non-obese and obese category. And because of Nebivolol's neutral effect on the lipid and carbohydrate metabolism, it suggests that it is one option for the BP control in moderately obese patients. So, in an obese patient with a borderline lipid profile, this agent was found to be beneficial. We can consider as a, if you consider beta blocker, Nebivolol should be preferred over other agents. Now, to summarize, like previously we were thinking beta blocker is a class effect, and the guideline also doesn't differentiate between different agents. But it's rightly pointed out by Dr. Modi also, all the beta blockers are not the same. They have a different cardioselectivity, they have different intrinsic sympathomimetic activity, different lipophilicity, and moreover, the different agents have different vasodilator properties. So we need to consider, we should need to tailor our therapy on the basis of the patient's clinical background, whether the patient is diabetic or they have a deranged lipid profile, or whether you wish to reduce the central aortic pressure. Accordingly, you can tailor your therapy. So vasodilating beta blocker seem to overcome all the general limitation of the conventional beta blockers. And these agents seem to have a better metabolic profile as compared to other beta blockers. And they improve the insulin sensitivity by reducing the insulin resistance, improve the endothelial function by improving the anosynthase, and reduces the aortic stiffness, and thereby reducing central aortic pressure. And at the same time, the most disabling side effect of the beta blocker, like erectile dysfunction, can be taken care by this agent. And all these benefit takes the vasodilating beta blocker to be considered as a different class of antihypertensive. With that, I ask Dr. Narayan to take the open for discussion and a few.
Thank you, Dr. Sharma. I think that was a very, concise, a very detailed, and a very illustrative discussion on Nebivolol. So now we agree that all beta blockers are not the same. And as Dr. Sharma has pointed out, Nebivolol has clear advantage over the others in 4 areas. One, of course, it is highly cardioselective, almost 10 times is cardioselective than the most popular metoprolol that we're using. It is vasodilatory, it doesn't have the PAD problems which you can have with others, and therefore it helps in heart failure management also. Then it has endothelial functions which will get rid of the impotency part and then give you so many other advantages. It has a great effect on central aortic pressure, and it is also lipid as well as glycemia friendly. So it has so many good points. Now the problem is that despite all these good points, this is one drug which has been underutilized, understudied. And as far as the NEHE study which you quoted, there's a question which is often asked that, aside the blood pressure values, it is the BP variability which is more important. And the study looked at BP variability. But I think it is unfair to compare it with the sartan. If you compare it with the calcium channel blocker, a long-acting calcium, then perhaps you would not know. Because BP variability, early morning surges are better controlled with calcium channel blockers vis-a-vis beta blockers and vis-a-vis the calcium. So with all that, I mean, where would you like to sort of place this particular molecule? Whether you would like to push it for uncomplicated hypertension, would you like to push it for hypertension with heart failure, or those with CKD and diabetes? or would you like to use it in acute coronary syndromes post-MI where our common usage is metoprolol? So where in your view, I mean, these are the questions that are in our mind and we can take it up with the panel discussion. So where would you like to put it, whether in hypertension or in heart failure? I personally, whenever these Torrent guys come to me and talk to me about Nebivolol, I say you try to push it in post-MI cases and in heart failure cases rather than, placing it as an anti-hypertensive, because it's a little difficult for us to substitute metoprolol as with Nebivolol as far as hypertension control. As Carvedilol, we will always like to put it as a heart failure agent. We don't use it as an antihypertensive. So with Nebivolol. So these are the questions in my mind, and with that, I would like to invite Dr. G.D. Ramchandani is here with us. Dr. Chandani, of course, is a very senior physician from Kota. And we were all discussing that we've never been to Kota, although that is one place where all the engineers and doctors, who aspire come from. He has been a professor. He is a professor of internal medicine at a dental college in Kota. He is the honorary secretary of the RSSDI, and he also the joint secretary of the National API. And he is member of so many associations, great interest in academics. And I'm very glad to have him here on the panel. So we can start off with your comments, Dr. G.D. Ramchandani, and then in the meantime, I'll look at some of the questions if there are any in the chat box. So you can make your comments and then you can make your questions and we will try to answer them. Chiefly Dr. Modi and Dr. Sharma will answer. I will just put in my little bits. So Dr. Chandani.
Thank you, Dr. Narayan, for nice introduction. First of all, I would like to congratulate Dr. Sunil Modi sir and Dr. Sanjay Sharma for an excellent talk about the beta blocker. I think for cardiologists, the beta blocker is a golden drug. It's, I think, the life-saving drug, which we heard since last 35 years, since our MBBS time. Our teacher says that it's post-MI mortality reduces, lot of advantages there. But in between, in few years after JNC came in 7, the role of beta blocker becomes little bit less. In nowadays, in algorithm, everywhere everybody says in hypertension you start ARBs or ACE inhibitor and diuretics and whatever.
Yes, carry on.
Beta blocker, but in fact, as Dr. Sunil Modi and Dr. Sanjay Sharma has elaborated the advantages, especially Dr. Sunil Modi sir, of beta blockers in various conditions, not only in the diabetes but COPD, in all other conditions. I think this is the beta blockers are the probably only drug that reduces cardiac complication in diabetic patients, because in diabetic CV cardiac complications are 2 to 4 times more. So any patient of diabetes, if have some sort of cardiac problem, definitely you should use beta blocker. And Nebivolol has the upper end with the other beta blockers like metoprolol and atenolol, because it not only effect on antihypertensive effect, but also decreases the heart, like other beta blockers, metoprolol and atenolol, they reduces the heart rate and fasting blood sugar and lipid disturbances. Nebivolol definitely has a less complication as compared to other beta blocker. So in our practice, still I am using beta blocker in diabetics and very frequently, as other diabetologists and
Dr. Chandani, we have a lot of questions, so you can start off with your answering them. Dr. Vineet Kumar Dwivedi is asking 3 questions. Says, why can I not use a beta blocker in bronchial asthma? Would like to answer that? No, I think Dr. Modi has already answered that, but you can make your comment as to whether you would like to use it in bronchial asthma or you would not.
Ideally, when we were in our medical college time, Dr. Modi already told that beta blockers, whenever there is a beta blocker asthma, there is a one word that is contraindicated, but not because beta selective is to be used, because as Dr. Modi has already discussed in COPD patients. So I request Dr. Modi.
Dr. Modi has said use it in heart failure even if there is bronchial asthma.
Yes.
Now this patient does not have heart failure; he just has hypertension. Would you still like to use it or not? That is the question. Dr. Modi would like, yeah. Yes, Dr. Chandani, please.
Ideally, in acute bronchial asthma, beta blocker should be avoided until unless it is indicated. Should avoid it, but beta selective other beta blockers may be used, but ideally because there are other anti-hypertensive for only hypertension.
Yeah, I think the answer should be that, you know, if it is pure and simple hypertension without any heart failure, I don't think.
से इलाज करते हैं ये इनको जो
They should be avoided.
आप मुझे आधे घंटे बाद फोन करो, मैं जरा एक वेबिनार में बिजी हूं बोलने में.
So I would say that, you know, don't use it in pure simple hypertension with bronchial asthma. There are other drugs that you said, but if the patient has heart failure, then perhaps you could use it, and perhaps Nebivolol might be a good agent there, because I, for one, am using Nebivolol for the last almost 10 years now. So, but I use it basically for angina and not for hypertension. So, Dr. Dwivedi also has another question. What about beta blockers in anxiety disorders, hypothyroidism and migraine? Any comments on that?
In migraine, it's probably beta blockers are the one. In fact, we can say it's a drug of choice. Other than other drugs also there, Cybelium, this other drugs are also there. But beta blocker has a very good role in migraine patients for prophylactic. Even I am personally.
Anxiety
disorder also, because in anxiety there is a tachycardia, and that patient leads to a vicious cycle. In that particular,
Dr. Sharma, would you like to use Nebivolol in a patient of anxiety and migraine, or will it be just propranolol?
Yeah, so the first choice for anxiety patients is propranolol. That's very important, and because it does have other effects also, apart from beta blocking.
What is the optimal heart rate in heart failure? Dr. Yudhishthir Das has asked, what is the optimal heart rate in heart failure? Is it going to be 60 or 80 or 110? What is it going to be?
So I usually target between 50 to 60.
Yeah, by the beautiful trial, you have to be less than 70. If you cannot get it with a beta blocker, if the dose is not well tolerated or you've gone to the maximal, then I think ivabradine has to be added, and the heart rate has to be below 70. Dr. Modi, what is your take on that? Because
yeah, I'll fully agree with you. You know, in the heart failure, again, lower the better, in the sense that 60 is definitely better than 80 or 110. You quoted three rates, so out of 60, 80 and 110, 60 is much better. And as Dr. Sharma said,
70,
yeah, as Dr. Sharma said, even if it is between 50 and 60, I won't reduce beta blocker or medicines to raise it further. So I agree with Dr. Sanjeev, you know, 50 to 60 is better than 60 to 70 or 70 to 80.
If the patient is asthmatic, has LV dysfunction, should we use beta blockers? The answer is yes. Dr. Modi has already said that. But which beta blocker would you prefer? That is the question. If the patient is asthmatic, LV dysfunction, what is your preferred beta blocker?
So should I comment on that?
Yeah, please.
So in my practice, surprisingly, as compared to Carvedilol, I use a good number of patients on bisoprolol. Bisoprolol is very well tolerated for all the COPD patients with heart failure. You start with a
Remember, you're talking about Nebivolol this evening.
No, sir. That's okay. That's okay. We do have a mixed use of your bisoprolol plus Nebivolol, and definitely you all will agree. The bisoprolol is very well tolerated in the patient with a COPD background, with a cardiomyopathy or with a heart failure. You start with a small dose, 1.25, and just see if the patient tolerates.
Dr. Chandani, what is your view on that? Dr. Chandani, what is your view?
In which condition?
Carvedilol. He says bisoprolol, sometimes Carvedilol. He doesn't want to use Nebivolol. So I'll have to have your view.
Nebivolol is not widely used. I have experience about the Nebivolol, but in my personal view, I am using Nebivolol in my diabetic patients very frequently. If I need after ACE inhibitor and ARBs, any drug, I always give the Nebivolol. And in pure hypertension.
Please, sir.
Varun, can I interfere?
Please, sir. Please. Yes,
see, if we are talking of heart failure situation, as far as I know, there are only 3 beta blockers approved to be used in heart failure. It is bisoprolol, carvedilol, and metoprolol succinate, not even metoprolol tartrate. The Nebivolol was used in only one trial, which made it to be approved for elderly age heart failure, senior trial. But generally heart failure, the Nebivolol, in my best of knowledge, has not been approved for use in heart failure for everybody. It is only in years.
Agreed, sir.
Actually, sir, we are the ones who will bring it up from, to class 2 and 2A and then go to 1.
Correct.
So, people you always used to say, the people who are the opinion makers will have to move these things up. So the idea was that if the patient has LV dysfunction and is also an asthmatic, would you still stick to carvedilol or would you think of Nebivolol?
I would fully agree with Dr. Sanjeev. In my personal experience, bisoprolol Concor is one of the best drug for such patients. I'm a lot user of bisoprolol, and the best thing about bisoprolol is that it reduces heart rate most efficiently as compared to any other beta blocker. So,
agreed, Dr. Modi. We are talking of a specific subset in heart failure. We are talking of somebody who has COPD plus heart failure. So you don't see any place for Nebivolol there, because I personally use it, in such patients.
No, so I have never used Nebivolol in heart failure.
Okay. The question by Shashank Tandon is, the 10 times potency of a beta blocker over metoprolol is probably talking of cardioselectivity. Does this actually translate into clinically proven benefits? Dr. Modi, you said that it is 10 times more cardioselective. Does it translate into
answer for this question is that we don't know whether this 10 times more beta-1 selective is really truly translated in the clinical. Nobody knows it, because if this was the case, then metoprolol should have been the useless drug. So it is not. So real answer in my mind is that we don't know whether it is translated clinical situations or not.
You already emphasized, Dr. Modi, that systolic blood pressure should not deter you from using a beta blocker. So he wants to know at what level you will not use it. Suppose he's 90 by 60. Would you still use it? Heart failure?
Yes.
Will it be 80 by 60 where it will deter you, or you don't think blood pressure is important at all?
Absolutely. See, except when the patient is in acute decompensated heart failure, ADHF, by standard criteria. If patient is in chronic heart failure with heart rate of 110 and blood pressure of even 88 by 60, I will start with very small dose of carvedilol, mostly because carvedilol has a lot of flexibility. And then on follow-up every third, fourth day, I will be able to increase the dose. See, my invariable experience is that those patients which we thought were not be able to tolerate beta blocker, if you start with a very small dose, on every follow-up they improve. Their heart rate improves, their blood pressure improves. So next time when patient comes, his blood pressure is not 88 or 90, his blood pressure is 96, 98. So I'm able to increase the dose very slowly.
So I think that's a very important point that you've made, sir. Now, Dr. Neeraj Kumar has raised the question, and I think this answer to his question is straight away no. He wants to know whether you should start a beta blocker in an acutely decompensated heart failure. The answer is no. You have to compensate heart failure first and then start. And when should we use brivabradin? That we have already said. If the heart rate is not coming down below 70, gone by the beautiful trial, then you have to add evabradin. Dr. Neeraj Kumar's question. Dr. Bagrecha said choice of beta blocker. We've already answered that. Then Neeraj Kumar Saab also wants to know if beta blockers can be stopped in patients with which, he says the patient is already on a beta blocker and he goes into acute heart failure. Now what do? Do you stop it, or you continue with a smaller dose, or you don't do anything?
Very, very interesting question, Varun. There is a trial by name of B-Convenes, which has compared stopping and not stopping of beta blocker during acute decompensation. And it clearly showed that if you stop beta blockers For the person who is already on beta blocker before that, if you stop beta blocker, it makes the situation worse. So continue beta blocker if you can. If you can means if your hemodynamics allows you to continue, it is always better to continue beta blocker even in the acute decompensation. Yes, starting beta blocker as a new drug in acute decompensation has not been recommended, but continuation of the drug has been shown very convincingly by this Be Convinced. It is Be Convinced
Yeah,
trial.
because that's what we generally do. Most of us will stop the beta blocker. So I would say don't stop, but in case you think there's some problem, you can probably reduce the dose.
Correct.
That's the most that you could do. Don't stop it altogether. So Dr. Chandani, would you like to take this question? Any contraindications to Nebivolol, or Dr. Sharma? Anybody of the two can answer that. What is the contraindication? When would you not use Nebivolol?
This is regarding hypertension or some other indication?
Any indication where you would not use it?
If the beta blocker is indicated for
any beta blocker contraindication, you should not. Any bradycardia, any block, any bronchospasm, I think you should not do.
Yeah.
Hypotension, I think we've already discussed. So basically, any bradycardia or blocks, if they are there, then perhaps you should not use them.
That is absolute contraindication.
And acute asthma.
And acute, yeah, that's we should not use. Hypertensive patient with obstructive sleep apnea will benefit from addition of a dose nighttime beta blocker. Dr. Shashank Tandon wants to know. Hypertensive OSA, low dose nighttime beta blocker. Why would you use a nighttime beta blocker?
I think
he probably wants to know whether.
So with the proven OSA, the first therapy is a CPAP. It really improves your nighttime heart rate, blood pressure, glycemic index, everything. The first therapy should be a CPAP.
Actually, we were discussing this with Dr. Ram, who's from Apollo, and he's a lot of. He says, yes, OSA needs BiPAP, but then BiPAP is not a reality in India. And even where it is prescribed, 100% follow is not there. Patients don't follow that advice 100%. So we speak of BiPAP, but most of the patients with OSA will not be on a BiPAP. So if you have to give medical treatment, I think medical treatment would be not for OSA, but for management of morning rises, and which is better managed by calcium channel blocker rather than with a beta blocker. So Dr. Chandani, want to make a comment on that?
Basically, as we all know that in OSA, the hypertension is mostly it's a resistant type, and patient may require 2 or 3 or 4 drugs sometime. So in that condition, you definitely require beta blocker.
No, he wants to know nighttime beta blocker.
Yes.
If patient has any history of cardiac problem, then definitely we should add beta blocker at night time. Otherwise, definitely we require beta blocker in that patient, especially sleep apnea syndrome, because 1 or 2 drug may not reduce the blood pressure in spite of a full doses, ACE inhibitor, ARBs, and even calcium blocker. So if patient has a recurrent history of tachycardia, or is a Holter is there and if tachycardia is there, then you can add this beta blocker at night time. Otherwise, calcium channel blocker, especially neuracilindipine, other drugs are better to use in night
Dr.
time.
Modi, would you like to use a beta blocker at night?
I have fairly, I would say, large experience of treating OSA patient hypertensives. Beta blocker is the ideal drug to treat hypertension in OSA, because OSA is basically hypoxia, and which leads to excessive catecholamine sympathetic overdrive. Most of
would it be at night or would it be in the morning?
I always use beta blockers in the night for every patient, not only OSA patient, even hypertensive.
Why is that?
Because
morning rise.
Peak effect of the beta blocker will come early morning. That is the time when sudden cardiac deaths and arrhythmias are maximum.
And others agree on that?
Yes.
No, the other panelists, do they agree to this usage at night?
Yeah,
preferably nighttime. Preferably nighttime. If patients tells me that I forget.
No, I'm asking the other panelists.
Yeah.
Yeah, sir.
I'm asking Dr. Sharma and Chandani, do they go with this view?
For me, sir, it's a 50-50. Either I give it early in the morning as soon as they get up.
No, but I think it is a good thought. I think Dr. Modi has made a good point.
Yes, yes,
That
yes.
if you are thinking of a morning surge, then perhaps it is a good idea to give it at least late evening, so that you don't have. So I think that's a very good point, Dr. Dwivedi. Thank you. There are several other questions. So do we have time? The torrent guys, can you tell us how much time we have?
It's
1
already
minute.
Already late.
I think it's over now.
So whenever you want to stop, we'll stop, okay? Because there are so many questions, about 50, 60 of them.
Beta blocker is a very subject which is discussed in a definitely.
Can Nebivolol be used with SGL2 inhibitors? The answer is yes.
It can be used, yeah. It can be used.
Yes. How effective are these vasodilatory beta blockers secondary prevention post MI?
Yeah, that is what I wanted to ask also, Dr. Sanjeev.
Said there is no definite prevention trial in the literature, but definitely because it's a when you take into consideration class effect, so definitely along with the favorable metabolic profile, if you use in a good doses and target at heart rate between 60 to 70, definitely even same effect on your prevention of sudden cardiac death and future cardiovascular events. Definitely we can use as a secondary prevention in the patients.
I want to ask Dr. Sharma, you must be using a lot of Nebivolol, or Varun, if you are using Nebivolol, the heart rate reducing effect. What do you feel in Nebivolol? Is it same as other beta blockers? I find it much less heart rate reduction.
Yeah, I agree. I mean, as far as the usage of Nebivolol is concerned, mine is also not too much. Basically, I use it on myself and patients with COPD, because I have some kind of COPD, so for angina, I'm using it. But I agree that I don't find it as a great agent for reduction of heart rate. Metoprolol brings it down. In fact, I must confess, as an anti-hypertensive beta blocker, atenolol really worked well. So had it not been for this ASCOT BPL, we would have continued to use tenoric and the things of the like. Good blood pressure control with atenolol. Lots of patients still are on atenolol. They won't give it up. So torrent guys, what do you say? Should we wind up? Because questions, as beta blocker is such a big topic.
We have. We are almost on time, sir. And I think if you are feeling interested, so you can take up some more questions, and then in another 5 minutes we will wind up, sir.
Okay, 5 minutes is the best beta blocker for renal replacement therapy.
Renal replacement therapy, you don't have any kind of comparative trial between different beta blocking agent, but in view of his metabolic neutral and all those effects and central aortic pressure reduction, definitely you can use it in good doses, like 5 to 10 milligrams of Nebivolol for renal compromised patients. But there is no comparison in a literature.
This migraine, would you like to use this in migraine? See, the answer to all these questions is, I think what we are trying to say is that this is one drug which has a lot of good properties. All the properties that were enumerated by Dr. Sharma, lots of good properties, but probably we've always looked at it as a weak beta blocker, one which does not have that kind of anti-hypertensive effect, one which is probably doesn't reduce the heart rate too well. And we are sort of getting used to, we are into using metoprolol in a big way. And in heart failure, we are used to using bisoprolol and carvedilol. We've never actually thought very positively about Nebivolol. So with this discussion, the idea is that we should start thinking. I mean, we have no real experience of using it in migraine or anxiety, but I think it has a place in far as heart failure is concerned, post-MI LV dysfunction is concerned, even with post-MI normal functions is concerned. I think it certainly has a place, and one should be pushing it for its usage in heart failure, especially if there's some renal dysfunction, patient with diabetes, patient who has complaints of erectile dysfunction, or a patient has some degree of COPD. I think these are the places one should think of using this drug. and it is up to us to see what it means. What discussion was pretty good. All the aspects were very well covered by Dr. Modi and then Dr. Sharma, and we had some great inputs from Dr. Chandani. So if you can have some concluding remarks from all the three speakers, we can sort of shut it down. Dr. Modi, you can start and whatever you want to conclude.
Yeah, it was a very nice discussion, and I just want to tell my colleagues, that don't discard beta blocker as antihypertensive, as we will be told again and again by the other group of drug promoters. So think of beta blockers whenever you want to treat hypertension, not as a primary agent, but at least as an helpful agent. And second thing, which in my experience, I want to tell that if you're not sure which beta blocker should be used, just use bisoprolol. That combines the properties of all beta blockers practically. I'm not sure about Nebivolol. I'll start using a Nebivolol, but then we'll have to take a year, 2 years time to know the good or the bad effects of Nebivolol. But if you are confused that which beta blocker, use bisoprolol. Is worldwide the maximum use of any beta blocker is bisoprolol, particularly in Europe, not in USA so much, but in the Europe, it is the bisoprolol which is used maximum.
It's a European drug. Dr. Sharma, your comments?
Yeah, that's nicely summarized by Dr. Modi. First of all, I would like to emphasize the point very well made by Dr. Modi. Is a beta blocker is a very underutilized, especially in patients with a heart failure, and we should prescribe the patient with most of the heart failure patients unless it's strictly contraindicated. And when you consider hypertension, definitely it's not been categorized as a class 1 indication, but still in a middle-aged hypertensive with some anxiety component or young professionals, I do prescribe Nebivolol in a good number of patients with a very good reduction of blood pressure and with a very favorable metabolic profile. And this drug does also, in addition to have a central aortic pressure reduction, and which really, I think in the long term, it will reduce the risk of stroke and cardiovascular event. With that, because it's a metabolic neutral, having a favorable factor of central aortic pressure, in spite of the guidelines, still you can use this drug as a class 1 agent or for your practice, especially in the middle age group for the future prevention of cardiovascular. Otherwise, for other indication, like we discussed about the heart failure and the concomitant CAD, we can use any of the beta blocker. The bisoprolol is one of the agents, as experience is there with Dr. Modi. For the heart failure patients, I've got a lot of experience with the bisoprolol as a default drug. And for the CAD concomitant, you can use a metoprolol. With those,
thank you, Dr. Chandani. Just a minute of your comments, and then we'll say goodbye.
First of all, I would like to thank speakers and Dr. Narayan. In diabetic patients, I already said that they have 2 to 4 times more cardiovascular complications, and there are some. Most of the time, patients are asymptomatic. So don't afraid to use beta blocker in diabetics, because still any diabetologist, they use beta blocker. It comes in the mind in the last, but patient has some mild problem and your workout should be done. If it needs, always use beta blocker. As Dr. Modi said, that's bisoprolol and Carvedilol and metoprolol and Nebivolol is also a good choice. In my practice, I'm not a cardiologist, so we are using more Nebivolol and other, but I have less experience of bisoprolol. But practically in European countries and other countries, biso and Carvedilol are more used in especially CHF patients and LVF patients. But in diabetic,
thank you very much. I think those were very 2 excellent talks, excellent comments, and we after this particular webinar, I think we need to think more about using Nebivolol wherever it can be rightly placed. So best wishes to everybody, and thank you very much, Torrent guys, for this opportunity. Dr. Saab, Dr. Modi, namaskar. Sharma ji,
thank you,
Chandani.
Thank you.
Great seeing you all after so much.
Thank you everyone, sir. I just want to give my thanks remarks to for this program, and I consider it my proud privilege to offer the vote of thanks on behalf of Torrent Pharma. The clinical update on beta blockers webinar has just been concluded successfully, and I'm humbled to see such a good response to this program. And we have just witnessed 250 logins in this program.
Oh.
Yeah, that was a good number, sir. So today's program, I would say, was very exciting, informative, and satisfying, sir. I also take this opportunity to express my sincere gratitude to the eminent panel members for sharing their experience and expertise with all of us. So thank you, Dr. Narayan. Thank you, Dr. Modi. Thank you, Dr. Sharma. And thank you, Dr. Ramchandani.
Thank you, sir. Thank you,
my
everybody. Good night. Take care.
My heartfelt thanks to all the distinguished delegates also who took time out of their busy schedule to attend the program, and without whom the event would not have been a success. Your trust on Torrent encourages us to conduct more and more such programs, and I'm sure your support will remain with Torrent Pharma in times to come. Thank you. And a wonderful evening.
Okay.
Thank you so much.
Bye-bye.
Thank you, sir.